We're at the American Academy of Ophthalmology in Orlando. My name is Sophie Bakri, and I'm a retinal specialist at the Mayo Clinic. And it is our pleasure to have with us Dr. Bill Rich. Dr. Rich is the Medical Director of Health Policy at the American Academy of Ophthalmology, and he's also Chair of the Health Professions Council of the National Quality Forum. Dr. Rich, thank you very much for agreeing to meet with us today.
My pleasure.
Dr. Rich, you have been Chair of the RUC Council, that's the
Correct.
Relative Value Scale
Right.
Update Committee. And what's the most important lesson you learned from your experience as Chair of the RUC?
Well, I think the Relative Value Update Committee is really puts work on a relative scale. It can work when you have physicians take off their specialty hat and try to do the right thing to make payment methodologies fair. The key to that is excluding the political pressures of your own society. You put on your RUC hat and you look at what makes the system fair, and that's best to all doctors. I think there's come a lot of criticism from primary care, but the reality is the RUC is not the problem. It's the lack of productivity with primary care, but the process works and it's not going to go away. One of our responsibilities is to look at overvalued service, not just undervalued one. The RUC is aggressively looking at that now. You've seen that a little bit in some of your decreased reimbursement for OCTs. Cardiology has gotten, so it's not just looking at undervalued, but overvalued services. It works, and I actually really enjoyed my 14 years in the RUC representing ophthalmology and 6 years as chairman.
Great. And what are the potential outcomes if the legal challenges to the Patient Protection and Affordable Care Act are successful?
That's a great question. The assumption is in the basis of the suits is that if we get away of the individual mandate, that seems to be unconstitutional, forcing someone to buy something, that the Accountable Care Act goes away. It doesn't. Everything that affects us in a big way is in Medicare. That still stays. What it does is it dramatically affects the commercial side, because when young people, healthy people aren't forced to join, the insurers are going to say, I'm out of here. So all these exchanges will collapse. So it's a threat to the integrity of global healthcare reform, but not to the big changes in Medicare that you're going to face and I'm going to face too.
So what's the outlook for physician reimbursement in 2012 and beyond, starting with the sustainable growth rate?
Well, but I'm Irish, so I can hypothesize and talk about this a great deal. I think you're going to see, the handwriting's on the wall, Sophie, that the traditional way we get paid, fee-for-service, piecemeal, is over. It's not going to go away, but the emphasis is going to be we're going to get paid on the quality of the care that we deliver, a passion at Mayo, and the efficiency with which that care is delivered, the patient satisfaction and the patient-reported outcomes. This is how we're going to get paid in the future. So pure fee-for-service is going to become less a primary source of income. If you look at the whole idea of bundling chronic care for a retina doc like yourself, AMD, and saying, okay, let's see what your outcomes are for all the patients in your network with a new subretinal neovascular membrane. What resources did it cost you in a year? If you could increase the quality and deliver it in a more efficient manner compared to the region, you're going to benefit financially. So it's not just going to be your fee-for-service patients. That's the emphasis on payment in the new law. So if you look at fee-for-service, there's not going to be any repeal of the SGR. They're going to hold that on there until this new concept of value-based purchasing is implemented. And I think we're going to do well. Ophthalmologists are smart. We have a passion for quality, as does Mayo. So I think Mayo Clinic and our profession should really benefit.
Do you think the Pqrs initiative has been successful?
Well, you know what? As you know, these are kind of starter quality metrics. For me as a general ophthalmologist, did you really look at the retina? Did you document if there was clinically significant diabetic retinopathy to refer to you? Did I communicate with the primary care doc? This was a beta site to see if they could engage physicians, capture their ability to report. So is it successful? Yes, in that we have actually done a better job than any other specialty. We have the highest participation rate and the highest percentage of docs that have actually reaped some financial benefit. But that's not the goal. The goal is to go from there to more serious outcome metrics that are going to be reported. So, has it been successful? You're looking at long-term health impacts that can't be measured yet, but that's not what its goal was. The goal was to engage you and I into reporting our quality outcomes, which will be available to the public reporting.
So do you think the FDA's Sentinel initiative for surveillance of medical devices will improve the quality of care for our patients?
I actually do. In our lifetime, we've seen some terrible things happen with Vioxx. How do we pick up the adverse cardiovascular effects? You know, word of mouth and a case here and a case there. Maybe Mayo putting together, maybe a group here putting together some adverse things. Then these things were reported to the FDA, they did a study, and then it was taken off the market. What the Sentinel initiative means is that in another 2 years, there'll be 83 million Americans that will be on an EHR. And if you have a new drug and device, you can query the Sentinel network and say, is there anything that's statistically different in this population? You don't even have you don't even have to have the scientific insight into look for like Vioxx and heart disease. It pops up, and then you can ask the questions. Is this statistically significant? So you're going to have real-time feedback on new drugs and devices. We won't see the problems with Vioxx. How about the metallic hips that have turned out to be a disaster in our society? It's not going to take us a generation to find out the adverse effects. So I'm very optimistic they're going to improve care.
That's great news. How will the distributed data network actually work?
That's a great question, and that shows a lot of insight in an institution that is integrated and is connected. They will actually go out and look at different registries. They'll look at patient populations. They'll look at our registry that we're going to develop with retina that's going to be reporting. They'll look at EHRs. And that, to get by HIPAA violations, all of the information on your registry, if you have one in your database at Mayo, is protected. The only thing that is sent into Sentinel is de-identified data. You have the data in your network, so it gets by HIPAA like that. And if there are adverse things, then they can go back and identify the patients. So that's how they protect the patient's privacy, but you still have control of your data independently in your network or your registry.
So what can ophthalmology learn from other specialties about the value of useful and usable registries?
It's huge. No one expects EHRs to improve quality. Forget it. It hasn't happened. It's not going to happen. But EHRs are the link to comprehensive outpatient registries. If you look what's happened in other registries in thoracic surgery, they had a decade to dramatically improve their performance. And it doesn't take a decade. There's something called the Hawthorne effect. If you start measuring yourself, all you have to do is make the intent. You know what? Your quality and your outcomes improve immediately, even before you measure it. And then you have like a dashboard. Can you imagine the benefit of having instant feedback with all the retina specialists around the United States? You don't have to wait for trials to go to retina someday. You have that feedback all the time. So I think it's really, really exciting. And you're going to see huge increases in quality of care. Anyone that's had a registry has documented this, and there's a 100% relationship. The registry increases quality, it decreases costs. So I think that's going to seminally change the way we practice. It will improve our outcomes, and it will save costs and perhaps benefit the institution financially. Our registry is going to be very different. In the thoracic ones and the cardiac ones, someone else puts the data in a hospital. For us, everything you do is kind of outpatient, except maybe 5–10%. So we have to find a way to get these data inputs from the ASC, the OPD, back to your office into a registry. And with EHR adoption, once that occurs, there is now software that can extract that data from your EHRs and mine to feed a national registry. So it's really exciting. And the Academy is committed wholeheartedly to develop an outpatient registry to meet the needs of all specialists.
So how will the registries be funded?
Interesting. Great question. The ones for cardiac surgery, heart valves and stents and things like that, that was mandated by the government. They said, we have to collect the data. So the hospital, the manufacturers have to pay for the registries. We don't have that revenue source. But however, there is a good business model the Academy has looked at. Suppose you just look at Pqrs, e-prescribing and things like that. That generates, if we get $5.1 billion in revenues, 4% of benefit of bonuses or avoiding penalties, that's $200 million a year. So that's a lot of money to find the couple $1 million a year to fund and maintain a registry. So you can take some of the money off the Pqrs gains and avoiding some penalties, and also dramatically increases the success rate for the physicians. Currently, if you do it with claims data, which I think you're doing at Mayo, I am, the success rate goes from 40 up to 90-some%. So all of a sudden, with $200 million in play, there are really good business models, we think, that can, at very low cost to the individual provider, really develop a robust, efficient registry.
Dr. Rich, thank you very much for enlightening us on all these important issues.
It was nice seeing you again, sir.
On behalf of Mayo Clinic, I'd like to thank you very much.